Hi, Nicole. Thank you
Hello,
so much
Amy.
for being here today. We're here to talk about perinatal experiences in mental health and the experiences of trauma and the work that you do at COPE. So I'll leave it to you to introduce yourself and introduce COPE as well.
Yeah, great. Thanks, Amy. Yes, I'm Nicole Highet, and I started COPE. We just started COPE 10 years ago. So we just had our
Happy
10th birthday
birthday.
the other day. COPE. I started COPE back in 2013 to really give a dedicated focus on emotional and mental health around the time of having a baby. Before that, I was at Beyond Blue for 13 and a half years, and I was fortunate enough to do some fantastic programs there. The community awareness campaigns, work around anxiety particularly, and manage the Commonwealth Government's $85 million National Perinatal Depression Initiative. So this at the time was the world's largest screening program ever that had ever been undertaken. And, I think I certainly learned a lot about that, but as COPE, the need for COPE really came about because that was very broad. Consumers would say, well, it's a general organisation, it's not specific to this area, and people see this area as unique and different, and it is unique and different. And so the need to tailor the information very much for this audience was very strong. And I also could see that we could do things so much better. So we could revolutionise the way we were doing screening. Pen and paper screening could be digitised. Referral pathways on pieces of paper could be digitised. And that was, beyond the scope of what Beyond Blue were wanting to do. So that's when I branched out and started COPE.
Amazing.
To really have a dedicated focus and really be there to provide as a peak body a digital infrastructure, I suppose, to support best practice.
Yeah.
And that's all underpinned by developing national guidelines and looking at how we can use innovation to implement best practice.
That's what we love.
That's what we love.
So being in this space, you've been in this space a long time now. What have you seen really change in the perinatal mental health space in the last 10 years, do you think?
Look, I think from a community awareness and consumer awareness perspective, I think the focus used to be just on postnatal depression. So people knew about postnatal depression. People did not really know about anxiety, and we know 1 in 5 women will experience anxiety both during pregnancy and postnatally, but people didn't really know about that. Anxiety during pregnancy or depression was, and we didn't look at conditions in pregnancy either. The focus was always just postnatal depression. So not only have we increased our focus to include anxiety, but also antenatal mental health conditions occurring. So that's been one of the really big changes. And I think that's sort of facilitated a lot by universal routine screening, both antenatally and postnatally, and the use of tools like the Edinburgh Postnatal Depression Scale, which also identifies anxiety. So certainly raising the profile of that. Previously, I think people would put the symptoms down in pregnancy, particularly just down to it's just hormones, it's just sleep deprivation because I'm not sleeping as well. And similarly, postnatally, it was just part of the hormones and adjustment or sleep deprivation. But now more and more people are recognising these conditions in their own right, and the need to really get assessment and treatment for the conditions.
I think it's quite poignant. We're obviously having this conversation for Birth Trauma Awareness Week, and this year the theme for Awareness Week is on postpartum PTSD. And so it's interesting we talk about how conversations have evolved, and we know it's not just postnatal depression anymore. We talk about anxiety, and obviously we were talking before saying, do you think people, like parents, know that you can experience depression or anxiety in pregnancy? And it's kind of, I guess the question is, do you think there's enough awareness out there around PTSD in the journey to parenthood?
Absolutely not. I think people still associate PTSD with war and what they associate with something you'd see on the news with veterans. It's certainly not associated with birth and birth trauma. I think just there's starting to be a growing awareness around birth trauma. I think there's more open discussion around birth trauma, and then I think that will lead to that next level of becoming more articulate about what that might entail. So, thinking right back to my Beyond Blue days, when Beyond Blue first started, everyone just talked about mental illness or mental health. No one put a name to a single condition like depression, and Beyond Blue was the first time that we put a name to a condition. In the same way then it extended to anxiety. And the same is happening in the perinatal space. At the moment it's gone from just talking about postnatal depression to now starting to recognise antenatal mental health conditions, and we're talking about birth trauma, and I think the extension of that will become talking about PTSD and what is that, and how does birth trauma, you know, general adjustment following a birth that might not have gone exactly to plan versus a traumatic birth and then PTSD. As we evolve and we're educating, and organisations like yours are so important in raising awareness and giving people the words and the descriptions to put a name to what they're experiencing. You know, people know, I think there's still a lot of stigma and high expectations around parenting and what that experience is supposed to be like. And that also particularly applies to the experience of birth. Birth is going to be all candles and meditation music, and it's going to be a wonderful experience. And when that doesn't happen, there's a lot of complicating factors, not only the experience itself, which might result in physical or psychological trauma, but also the feelings of failure, the feeling of disappointment, the feeling of, this is my entry to parenthood and I've already failed at the most critical time. All those things are layered on top, which make this an extremely complicated space. And why health professionals need to be specifically trained in this area, it's different. And we need to understand the nuances and the complexities to really provide quality evidence-based care that can show that we relate to our patients' experiences as well.
Yeah, I love that, obviously, yes. Interestingly, last year, the British Medical Journal released some information around postpartum PTSD, which they say affects around 3 to 6% of birthing women. And of course, it affects non-birthing parents and birthing people. But interestingly, they say it's quite commonly misdiagnosed or diagnosed perhaps as depression or anxiety, and requires a different treatment and more specialised trauma treatment. And so I was obviously very excited to see your new perinatal mental health guidelines, and for the first time talking about psychological birth trauma. Can you talk to me about that, about the guidelines, what it means for clinicians and also for parents as well?
Look, the guidelines are really fundamental to our work and also to the work of then clinicians and for consumers who need to be informed about what is evidence-based treatment, what should I be, what are my options, and making sure that everyone is equipped with evidence-based information, because there is a lot of misinformation out there. And so this is why the guidelines is so critical and needs to inform all of our work, but also the work of other organisations as well. The inclusion of birth trauma wasn't easy. We didn't receive funding to extend the guidelines. There's a number of areas we wanted to include in this round of guidelines: eating disorders, birth traumas, and managing around congenital anomalies, because obviously that has big psychological impacts as well. Anyway, with no extra funding, we had to choose one area, and so birth trauma was the area we focused on because of that reason, because we are doing screening and assessment to identify those at risk of or experiencing mental health conditions in pregnancy and postnatally. So the inclusion of birth trauma as part of that postnatal experience assessment. Was your birth experience traumatic? Would you describe your birth experience as traumatic? Is part of the universal routine screening. So we need to know what to do with that if someone does indicate that. So the guidelines is playing a really important role in, I think, first of all, raising the profile for health professionals around birth trauma is a major risk factor. It's one of the risk factors that we need to look at alongside the anxiety and depression scores that might come out of the screening process, but asking that question and having the conversation around that as with other risk factors. The guidelines are very important then in taking us to, well, what if a person does disclose that? What does the clinician do? And really emphasising the role of trauma-informed cognitive behaviour therapy as a treatment, or EMDR as an evidence-based treatment. And also really important is not getting the woman to relive her experience. A health professional might think that they're doing the right thing by doing that, but actually that can make it exacerbate the trauma and distress for the individual. So understanding more about PTSD, how to recognise it, and asking the question. If we don't ask the question, we're not going to find out. If we're not going to find out, we can't help. So that's where the guidelines is so important. It's raising the profile, but also equipping the health professionals with the skills for assessment, and then knowing what treatments. And of course, that information is all very important for the consumer as well. It validates their experience. It helps them to understand what treatments they should be looking at or asking about, and understanding. And this is where things like having a dedicated perinatal mental health directory of services is so important, because people need to know when they're referred to a clinician that the clinician gets it. They can do a search on the ECOPE directory for birth trauma. They can find community support organisations like yours to provide support. They can find clinicians with trauma-informed care who know how to deliver these evidence-based treatments.
It's really powerful, and I think, yeah, so it's kind of a two-pronged approach. I'm getting the sense is that it's actually equipping clinicians to ask vital questions, but enabling parents an opportunity to share, and that is really the nail on the head. You talked about validation, which is something that our community needs, and that's what they want. And interesting that the sharing the story don't make them share the story. What we do see as well is that women and parents often want an opportunity to share their story in a safe environment. So it's providing that opportunity, but letting that individual do what feels right for them as well.
Absolutely. And that's where I think, you know, the role of organisations like yours is so critical. It's giving people the space to listen. They might even be too traumatised to even speak at that time, but it validates that they can relate to the words of someone else in a way that a checklist might not, or a conversation with a clinician might not. But just when we were doing also the research for the Truth campaign, which had a specific focus on birth trauma as well, that was one of the key themes that came through, and why we needed to profile it in the campaign. A lot of the trauma, not only from the incident of the birth itself, which might have had complications, but the experience by the way they were treated by health professionals, that was a really strong theme about how that really compounded the trauma. They weren't listened to, their experiences weren't validated, they were minimised, they were brushed under the carpet. So this is why things like screening is so important, because it puts it into the infrastructure to make sure that question is asked. Otherwise, it will be forgotten about, and the poor parent who's in need of help, it's going to exacerbate their mental health conditions. It does, and potentially things like PTSD never get identified, never get treated. It affects their future of even contemplating having children in the future, because they're so traumatised. It has long-term, far-reaching impacts.
So they've got an opportunity.
Absolutely, and we need to maximise that opportunity. Look, another opportunity for really having a focus on the consumer is the Ready to Cope app, where people can download this free app, receive information right through their pregnancy in the first year. We talk about in the app during pregnancy each week, we talk about the lead up to birth. We talk about managing expectations. We talk about, you know, you can have a birth plan, but you can only plan so far. So we try to really get people thinking about, you know, being aware of your expectations around birth and not setting yourself up. We also then talk in the early postnatal period about, well, what if birth didn't go to plan? What are the signs of PTSD? How would I recognise this in myself or my partner? So again, the app is a really innovative way that we can drip feed that information and profile the topic of birth trauma, and make sure people have access to further information if that's something that's resonating with them, and then find services like yours or mental health treatment services on the directory.
I mean, I think that is really powerful, because one of the reasons that we chose to shine a light this year on PTSD, or postpartum PTSD specifically, is around what I said to you about that sort of misdiagnosis. So if parents can recognise the symptoms of PTSD, I do think that's really powerful, because it's so important to acknowledge that anxiety and depression can be symptoms of trauma.
That's right.
And so they're brave enough to seek support, and they seek support from a clinician that might be quick to think, okay, well, this person's depressed, but not looking at the bigger picture. And that bigger picture is to ask about the birth experience.
Yes.
What also is really exciting about your guidelines is the fact that you talk about fathers and non-birthing parents and making sure you're checking in on them. We just haven't done a good job of that historically. And And I think there's real barriers for fathers or non-birthing parents to seek support because they're like, well, I didn't go through the birth.
Yeah.
But their responses to what they've experienced is completely valid.
Yeah.
So, yeah.
Absolutely. So that is a whole new area of the guideline, in that we are providing recommendations about if you are screening fathers and non-birthing partners. So that was the first question. If we were going to screen fathers and which screening tools do we use? What screening tools are validated? So, you know, there is evidence there, and the guidelines indicates that you can use the EPDS with a lower cutoff scores for fathers, particularly. You could also use the K10 as another approach for fathers. And then there was no psychosocial screening tool to look at risk factors. So like right back when we did the first Beyond Blue guidelines, we had no psychosocial screening tool. So the expert committee formulated its own questions. So we had an expert committee of fathers and partners, and we really amended the ANRQ to specifically look at the specific questions that might be, and the language, to make it more pertinent.
So when was that done?
That was part of the guidelines. So now you can see in the guidelines.
Oh, right.
Screening
So this
tools,
is all brand new.
It's all brand new.
That's incredible.
So now there's questions around, you know, the way when we describe, you know, have you ever had periods where you felt depression? When we're describing some of the symptoms, we include things like anger, which fathers might relate to. When we're talking about life stresses, we're putting in specific life stresses which might be pertinent to fathers, like financial worries or other factors which particularly might relate to fathers, or, you know, an unwanted pregnancy. Things that fathers might particularly relate.
What about including, you know, they might have to be the primary carer because of what the birthing parents experienced?
So
that's in there?
Exactly. So well, if a father is the primary carer and they're the one who are going to the maternal and child health nurse, what does the maternal and child health nurse do? Well, now they can use the specific version for fathers or partners. And look, some antenatal care providers are screening fathers in the dads groups that they have as part of the antenatal classes. And so this will be really interesting to have this conversation in another 5 years and say, what is happening with screening? So at the moment we had to say, well, you know, there's always that thing about, well, for a hospital, the patient is not the father is not the registered patient, but many services are wanting to do something for fathers and partners, and it'll be really interesting to see how this evolves and might influence policy and practice in the longer term. But that's where we are now, and things, you know, starting with the guidelines is always a really critical step to putting the line in the sand and say, right, this needs the attention and this is what we do with it.
It's incredible. It's just absolutely incredible. So where do people find the guidelines? Are they available now? How do we, so the guidelines are for clinicians, and then so where do clinicians find that? And then the iCope screening, that is for clinicians and consumers, right? So
the iCope screening is being rolled out across every public maternity hospital and every maternal and child health centre in Australia. So it's made available.
That's incredible.
We're right across Victoria. We started last year in Victoria. We're in now over 95% of public maternity hospitals, and I think about close to 88% of maternal and child health clinics. So this is revolutionising the way that we're doing screening. So no longer, you know, pen and paper, asking the person to feel like they're completing doing a test and giving the results to the health professional to score the test and interpret the responses. It's very much more personalised. The parents can do the screening on their own mobile phone. They can do it at home prior to the appointment. So it's a lot more private. It gives people the time and space to think about their responses, and importantly, not only does the system generate a clinical report for the clinician, guiding them about what the scores mean and what to do next, the patient can also receive their own report, which goes through any risk factors or what their Edinburgh score means and link them to referral pathways. So it really is...
are there enough referral pathways? Do we need more?
It depends where they are. So it depends what the condition is, and it depends where people are located. One of the great things around telehealth is that is continuously available. Living in Melbourne here during the pandemic, there were no services available, but people could access services from interstate where they didn't have the same demand, for example. And this is why the eCope directory is so important, because people can do a search for telehealth. They can, if you're in a rural area, find a specialist in birth trauma or any other area because they can access telehealth if they want to. So it's having that continual referral pathways. But another area I think we do really need to expand is better upskilling our mental health professionals to have more training and qualifications. As we spoke about at the beginning of the conversation, there's lots of nuances, there's lots of differences in this space, and health professionals need to have that specialist training.
And you're doing some training, aren't you? Has that launched now?
Yes, so we always have ongoing frontline training for health professionals so for the midwives, the GPs, the obstetricians, about screening and identification. And then more recently, we've developed training courses for mental health professionals who want to become more specialist in perinatal mental health.
Okay,
so they're all available and continuously being updated. But yeah, going forward, I think we really need to continually upskill the workforce, particularly as we roll out the screening and it's becoming more universal. We need to equip the workforce to respond to identified cases. Look, it always amazes me, services who say, well, we're not going to screen because we don't have anywhere to refer.
We hear that a lot as well.
It's pathetic. You would not say, I'm not going to screen this woman for breast cancer in case she has breast cancer and I have to do something about it. We know that if we don't identify and treat mental health conditions early, they can become exacerbated. They impact on the ability for the woman to care and her partner to care. It impacts on the relationship. It impacts on bonding and attachment. It impacts on child development and so on, right through to that child's trajectory. So the excuse of, I'm not going to screen because I've got nowhere to refer, quite frankly, is pathetic. And that's why things like the eCope directory, the referral pathways, they are there, and we will work with services doing screening to populate the referral pathways. Women can find the services on their own following screening or at any other time, but they're also at the fingertips of the health professionals.
It's a two-pronged approach.
Absolutely.
Of awareness as well.
And making sure everyone has access to the resources. Everyone with depression, and this is another big thing around the guidelines, I think. Quite often we're good at screening once, sometimes in pregnancy, and once postnatally. The guidelines recommend we screen both early and later in pregnancy and later in the first postnatal period. Everyone's done their 6 week screening, it's done. It's not the case.
Enough.
We know most cases of things like anxiety and depression occur after that period, but no one's thinking about it. So I'm very committed to making sure that we start really targeting those areas, and quite often things like birth trauma or PTSD don't necessarily come out, particularly PTSD, which is diagnosed from 3 months postnatally. No one would pick it up because it's like, oh, we've done the screening. It's like we need to get better at doing that second screen, both antenatally and postnatally.
Yeah, we'd love to see extended screening and more support offerings beyond 12 months as well. That's the challenge, and that's, I think, that we need to see change because people fall through the gaps.
Which
and
is
that's
why
we have to have these conversations.
Exactly. And when we're talking more about the first 1,000 days, it's broader. And I think that's something, actually, going back to your first question, that has changed a little bit over the last 5 or 10 years, is there is a focus on the broader context of perinatal mental health. It's not just, people used to think it was the first 6 to 8 weeks postnatally, but now it's a year and we're moving into the first 2 years.
Yeah. We need parents to know that it's not too late, but we need clinicians to know to treat it in a timely manner, whatever it may be.
Exactly.
Yeah. Well, thank you so much. Thanks for your time.
Thank you so much for the opportunity.
We'll look forward to the big launch of the guidelines.
And I really look forward to, COPE really looks forward to working with you and your organisation to continue to raise the profile and advocate for these areas that we've made a lot of progress, but we can still do better.
So much better. Thank you.
Thank you.
Thanks a lot.